Chairman, thank you. Mazzani, it's good to have somebody officially from the middle of nowhere. That was, by the way, determined by the Washington Post. And they had a criteria. You had to be 1,000 residents or more, furthest away from metro area. And the top three in the nation stacked rank were all in Northeast Montana. And by number 4, you went to Nevada, some small place. So you are literally from the middle of nowhere and have the gold medal. So we're glad you're here. I think you bring a very unique perspective, and I know your colleagues here who have shared similar testimony have similar challenges. In your testimony, you mentioned some of the notable characteristics of providing health care in these very rural and remote areas of the country, and I know when people are sitting in gridlock traffic, they're yearning to move to the middle of nowhere sometimes, and that's why we're seeing a lot of growth in a lot of parts of Montana. But we're seeing health professional workforce shortages across the board. Ms. Rich spoke about the acute challenges, the numbers you are facing right now in your facility. But these shortages have outsized effects when you're talking about rural communities where populations, the pool that you can hire from are limited, small to begin with. Could you speak a bit more to the rotating provider model that you implemented at your clinic, as well as your recent partnership with Intermountain to facilitate the behavioral health responses in the emergency room?
Yeah, so our rotating providers, that was an organization that we luckily found because we were having, we lost our orthopedic surgeon, and if we don't have that, patients have to drive 300 miles, to have a hip or knee replaced, so we felt that was a critical need. So it is 24/7 coverage. We have 3 full-time providers that rotate in. They live elsewhere in the United States, and they fly in for their rotation. They do a 10 to 12-day rotation, and they're on call 24/7. They run a clinic, and then they do surgery. And that model worked so well that we achieved that for general surgery, and then OBGYN as well. And then we just, unfortunately, our radiologist is moving, so we are possibly looking for that model for radiology.
Dr. Herman, thanks for your testimony and highlighting the Essentia Health work serving rural communities. My ancestors that came from Norway stopped in Minnesota for a while. Then they heard the mosquitoes were smaller out west, so I think they kept going. You've had some of the most successes in Minnesota, but there are others that are interested, I know, in adopting similar approaches as well. So maybe for us here in this, in the senators, and for those of us listening to this hearing, what are some observations and best practices that you see that have worked to drive your success? What are some of the barriers you've had in the process of trying to implement value-based care, as you mentioned in your testimony, in more rural areas?
The challenge that small providers have is the challenge of scale. It's hard to build the infrastructure to support a value-based program when you have 2 or 3 providers in a small community. Essentia Health is a conglomeration of more than 30 different practices across northern Minnesota, Wisconsin, and North Dakota that got together because we have a common mission, and that's to serve our patients better. I think the federal government could provide support for, just like when we live in rural areas, we're very familiar with the cooperative model. There's no particular farmer in a small community that can own his or her own silo. But if you can get together and provide that infrastructure, whether it's the IT infrastructure or the care infrastructure, you're much better able to do that. I also think that some value-based programs are rightly very concerned about the outcomes, but when you are in a small community, you are a slave to the law of small numbers. For many of those communities, the process is more important than the outcomes. So if you're measuring the cost of care in a small community, one patient with breast cancer can certainly raise the cost of care, and you end up missing your targets. Mm-hmm. So how do you get the right process measures to support that particular type of care, and pulling it together with the infrastructure that can support not just a large healthcare system, but could support many small healthcare systems?
So here's that. Do you get, is there sympathy to your argument in terms of, since the pool is so much smaller,
Right.
where you could have one particular patient could drive means and so forth out of whack.
Right.
How do you deal with that?
Yeah, measurement matters. So what are the things that you're doing that get your average patient healthier? The advantage of those small numbers is you can take a look at almost every patient, particularly if you have an electronic health record supporting that. It also allows you to get a fine view of the social determinants of health and what does the community need other than a healthcare provider to support some of the care of the members of their community. If you're living in a food desert and people are eating high-salt foods, the chances of them being rehospitalized for congestive heart failure is very, very high. So rather than just taking a look at the patient's path from illness to wellness, what's the patient's path to sustain themselves after they get that? And that's building the community.
Thanks, Dr. Herman.